Next. Hi, I'm Dr. Julie Bruno.
Hi, I'm Hollis Silverman.
And today we're going to talk about post-traumatic stress disorder. We're going to first talk about what the diagnostic criterion for the DSM-5 is. First, you have to have experienced some form of a life-threatening experience, and that is either directly, indirectly, meaning like a EMT or a nurse or a doctor, through the telling or retelling of a traumatic event, and then
Witnessing a traumatic event.
exactly, and witnessing it.
So if you're in combat, if you're a soldier, and you saw something,
Yeah.
that can cause it. Or even if you're watching the news and you happen to, be very, very traumatized by, by violence that's occurred. And we've had some violent episodes. Obviously, in 2016 we did. So.
And now in 2017 as well.
You're right. Absolutely.
So, and then some of the symptoms that occur because of it would include hypervigilance, meaning that you're constantly scanning your environment for potential threats, avoidance of specific situations. Like with the vets, it's a lot of veterans don't like crowded crowds or crowded spaces.
A lot of irritability.
Yep.
A lot of numbness. So they get very numb when it comes to emotions and their feelings. It's just very hard to deal with a lot that's going on. They just kind of want to withdraw. I would also say a lot of depression can happen.
Flashbacks, intrusive thoughts, ruminations,
night terrors,
negative self-thoughts, feeling helplessness and hopelessness,
anxiousness, nervousness, always kind of being in that, as Dr. Bruno mentioned, that hypervigilant state, always kind of being in that fight or flight mode.
And a very important part of the diagnostic criterion is that you have to have 30 days of the symptoms before you can be diagnosed with PTSD. Prior to that, you would be diagnosed with acute stress disorder. So some people have, like my handyman, he had a very horrible crash where he went across 4 lanes on 95 and crashed into the wall at 3 o'clock in the morning. And I spoke to him a couple days later, and he's like, I keep on seeing myself crashing into the wall. And then about 2 weeks afterwards, I spoke to him, and he's like, I'm not experiencing those symptoms anymore. So, he was going through an acute stress episode.
Absolutely. And so with PTSD, Dr. Bruno, what do you think that some people can do, to help themselves, kind of work through the PTSD?
Well, there's a number of treatments that are validated and used, especially with the vets and across the board. That would include cognitive behavioral therapy, EMDR, which is a lot of people profess to be great, but it's about 50-50 in my experience with clients. We call it narrative therapy, but they call it virtual exposure therapy, which is basically when you come into your therapist's office and you gradually explain and write down your experiences in as great as detail as possible. Medication, whether it's medication to help with some of the more difficult symptoms like paranoia, or irritability or hypervigilance or depression. And some of the newer things, but they're really old things that are coming back, which is microdosing of acid, marijuana, and MDMA. Now, the microdosing of acid and the THC is used actually as a medicine that you would use outside of the therapy experience, but the MDMA is used mostly within the therapeutic environment, which would help you with the virtual exposure therapy because it facilitates a general well-being, and also a need to talk. The thing with people who are going through trauma is they sort of get like lockjaw syndrome. They can't speak it, whether it's because they feel like if they speak it becomes real, or they they feel like they're going to go crazy and they're never going to be able to be put back together, sort of like Humpty Dumpty.
Yes.
So it really facilitates, and it makes therapy go so much quicker as well. You know, it could take years for someone to detail what they went through versus 5 sessions with ecstasy. So
absolutely. And so a lot of times, even with my patients, Julie, I have them write down, yes, I mean through the narrative therapy and expressive writing, yes, their whole life story or their whole traumatic experience, and it has to, you kind of have to get to that point. So it's definitely not a fast process. It takes time, and it takes time for that person to really feel comfortable to do that, because in a way they you could be re-traumatizing yourself to a certain extent.
Right.
But also, if that person wants to work through that trauma, you kind of have to go through that process, because once they do, there's a lot of healing that can be done.
So what would make, so I guess what I always get asked is, why do some people develop post-traumatic stress while others, you have all these vets going into the Middle East or to wherever, to combat zones, and only some of them come back with post-traumatic stress.
Yes.
Or maybe a lot of them come back with post-traumatic stress, but some are able to cope with it more than others. And that's a very complex answer, right?
Yes.
Do you want to take a stab at it?
Yeah, definitely. So obviously there's some risk factors that, can come into play with certain people versus others. So some of the risk factors can include if there's mental health issues in one person versus another person. In one person, you can also see they happen to just have more resiliency as opposed to maybe that other person. And that could be maybe the way that they were parented as a child. It could be maybe their socioeconomic status, if they came from a rough neighborhood.
Their temperament.
Yes.
Your attachment style.
Support system.
Absolutely. When you come home or after a trauma, if you have a good support system, you're sort of encouraged to go out and talk about it and work through it, and go back to your friends and family, and they sort of push you through it almost.
Absolutely. Even in the workplace, I would say too, you might not always get that, but even if you are having, if you are experiencing a lot of symptoms, letting, somebody that you work with, even if it's not, just a work, because you're at work, sometimes more often than we are at home. So it's good to just, have that confidant at work that you can talk to about it.
I agree.
Yeah.
I agree.
Yeah.
Also, some people gravitate towards coping that's not positive. So
Yes.
you can have co-occurring disorders, like substance abuse, which is huge, alcohol, cocaine, whatever it is, heroin in the Midwest. When you talk about socioeconomic status, really talking about really going far back and going and talking about nutrition, talking about not just education, but access to care. These things kind of create first steps or missteps to one's ability to cope. So
Absolutely.
if your parents are not there, or they're working because they have to put food on the table, and then you don't eat for a few days, you're stressed out, then you might deal with some depression issues, and then you think, I'm going to join the military, which is a wonderful thing, serving your country. And then you go into combat, and then you have post-traumatic stress, where you've had all those little tiny micro stressors along the way, sort of set up set the table for you.
Absolutely. And even also a past abuse history.
Oh, yes.
Childhood sexual abuse or physical abuse or emotional abuse in the home. Those are definitely, as Dr. Bruno mentioned, those are going to be little microcosms that are going to cause, that build up to where, your coping mechanisms, may be maladaptive, which is what we say, maybe using drugs or self-harm or thoughts of suicide. Those are definitely things that can happen.
But in the end, I encourage you to seek help.
Yes.
There's so many wonderful places online, and with a caveat is don't get sucked into online forums where you get stuck in the trauma phase of the disorder. It's a working through, not just staying stuck in that phase.
Absolutely.
And the VA has wonderful resources inside and out. Don't be afraid to see a therapist. It could save your life.
Absolutely. And also, I just want to mention before we end, there's also something that there's a lot of literature on, something called complex, post-traumatic stress disorder. And oftentimes, people get diagnosed with schizophrenia as opposed to complex, post-traumatic stress disorder.
Women
do, yes. So a lot of the same symptomologies, such as paranoia, hypervigilance, anger, emotional dysregulation, some of those same symptoms that are in PTSD can be manifested or look like schizophrenia, but really it's actually complex PTSD.
Absolutely.
So I just wanted to give a little snippet on that.
Thank you.
Yeah, thank you.
Well, I'm Dr. Julie Bruno.
I'm Hollis Liverman.
Have a good day.